This is a case-based discussion of a few challenging cases in uveitis, which will be presented by our KSOS distinguished faculty. We have a few challenges in these cases, which will be solved by our keynote speaker, Dr. Partho Pratim Mujumdar, will be helping us in solving these cases. So let me start. At first, let me welcome our chairperson, Dr. Partho Pratim Datta Mujumdar, who is a senior consultant at Shankar Netralaya, Chennai. He has many publications to his account, and he's also the founder cum chief editor of the e-Opta portal. Now, may I welcome Dr. Dalia Krishnan, who is the first speaker. She'll be presenting a case, Double Trouble with the Dicey Bacillus.
A very good afternoon to all. Thank you, Dr. Rajeshri, for giving me this opportunity. So, my double trouble with the Dicey Bacillus. It starts with a 63-year-old female patient who came with defective vision in the right eye of 1 week duration. There was no history of pain, redness, or headache. History of contact with tuberculosis was present. So, on ocular examination, the best corrected visual acuity in the right eye was 612 with defective color vision and a grade 1 RAPD. Anterior segment showed few cells in the anterior vitreous. Perimetry showed a dense superior peripapillary scotoma. Left eye was normal. So on fundus examination, the right eye showed disc edema with hemorrhages. There was macular edema with exudates and macular fan pattern. Indirect ophthalmoscopy revealed multiple subretinal elevated lesions in the posterior pole. Left eye fundus was normal. So the OCT macula confirmed the prominent disc edema with peripapillary subretinal fluid and intraretinal hard exudates in the papillomacular area. There was a large hyporeflective lesion in the choroid in the subfoveal area with the elevation of the overlying retina. Left eye OCT was normal. So fundus fluorescence angiography was done, which showed disc leak in the early phase with increasing hyperfluorescence in the later phases. There was no vessel leak or no leak corresponding to subretinal lesions. Left eye was normal. So here we had a case of unilateral neuroretinitis with a multiple choroidal nodular lesions in the posterior pole in a 63-year-old lady with a history of contact with tuberculosis. So first of all, we want to rule out ocular tuberculosis. Also, we want to rule out sarcoidosis, ocular syphilis, and choroidal mets. So the blood investigations revealed a lymphocytosis with high ESR of 65 and a positive Manto and IGRA test. Serum ACE, TPHA, and HIV was negative. MRI brain with orbit was within normal limits. HRCT thorax showed fibrotic changes in the apical segment of both upper lobes with bronchiectasis in the right middle lobe and the left lingula. There was enlarged paratracheal lymph nodes. So chest physician consultation was done, who advised bronchoscopy with IBUS TBNA, but the patient was not willing. So with the COTS median score of 5 and an interquartile range of 0, ATT was started under the chest physician's care with INH, rifampicin, pyrazinamide, and levofloxacin in place of ethambutol because the optic nerve was involved. Along with this, we gave systemic steroids at 1 milligram per kilogram in tapering dose. So in the initial follow-up, after 2 months, her best corrected visual acuity and the color vision came back to normal. The optic disc edema was reducing, and the choroidal lesion also was resolving. After 2 months of ATT, she developed jaundice with fatigue. A gastro consult was done, which showed 10 times elevation of liver enzymes with a serum bilirubin of 2.7. So viral hepatitis was ruled out and ATT was stopped. So in the follow-up in the 4th month, when she was not on ATT for the past 6 weeks, we saw that the choroidal lesion was increasing in the inferior macula. Again, start of ATT was asked for. ATT re-challenge was done multiple times, one with simultaneous with all drugs, then with INH and levofloxacin, which showed that INH was causing the hepatotoxicity. So in the 8th month, she was started on rifampicin and levofloxacin, initially with 300 mg, then increased to 450 mg for rifampicin. And during this time, the choroidal nodule was persisting. So after 6 months of ATT with rifampicin and levofloxacin, in the right eye, the choroidal nodule lesions elevation was still seen. Also, by the 13th month, we were seeing there's a new lesion in the nasal retina, and the macular lesion was increasing in size. There were also 2 lesions seen in the left eye. So now we advised addition of ethambutol in the ATT. So a baseline perimetry was done, which showed a subtle superior peripapillary scotoma still persisting in the right eye. left eye was normal. So with rifampicin and levofloxacin with ethambutol, this choroidal lesion was resolving in both the eyes. So in the last follow-up on November 2nd, after 4 months of ATT with ethambutol, best corrected visual and color vision are normal with resolved disc edema in the right eye and no choroidal lesions in both the eyes. So in a literature review, we found that our patient had a grade 3 moderate level of hepatotoxicity, and the possible regimens, whatever seen, all contain ethambutol. So my questions to the panel is, this patient had initial 2 months of intensive ATT therapy, then intermittent ATT in the next 6 months, then 2 drug ATT in the next 6 months, and 3 drug ATT with ethambutol for the next 4 months. So what are the suggestions to complete ATT in such a patient who develops drug toxicity or drug allergy? What should be the total duration of the treatment? According to the pulmonologist, we could stop ATT after these 10 months of therapy, continuous therapy. So any similar experiences? And the opinion on addition of ethambutol later, was it a wrong?
I think I'll just try to summarize it in a single excellent, brilliantly managed case. But what I would have done, I would have started ethambutol from the beginning only. I'm a little skeptical of going into the levofloxacin related treatment, because if you see that there are sufficient literature that it should be used as a second line treatment. And we have to understand that we are always treating a latent tuberculosis. So sometimes we are not sure that how much infection we are dealing with. So we should not actually go and spread the what we call this resistance. No? So that is my primary concern. And we have treated a series of patients with optic nerve involvement ocular tuberculosis. I think it is more little bit of myth that if there is a optic nerve involvement and if we give ATT containing ethambutol, it will cause more harm. I don't think it is supposed to cause more harm. The chances, the risk will be same as you would give a ATT to a normal patient only. One good thing about this is these are the patients we give little higher doses of corticosteroid that helps in resolution of the optic disc edema, not the ATT.
How you monitor ethambutol toxicity in these type of patients with optic nerve involvement?
Any patient ethambutol, like we normally what happens, we give it only for 2 months. So we monitor the patients regularly. We call the patients every month and just see them, and later we ask them for 3 months or 4 months.
In the modified ATT regime, they are giving more duration, no, ethambutol.
Yeah, that I have spoken to my chest physician, so she's quite here, so she makes it.
Oh, only 2 months you are giving ethambutol. Okay.
Sir, before starting ATT, do we have to get an HFA, color vision, all those things done when we are for?
We don't do.
Nothing
LFT
of that.
we do.
That's all.
Just to see that the baseline, better to have a baseline LFT, to see that whether it is going on.
And if the patient is on modified ATT, how you titrate the duration of ATT in a ocular TB? I mean,
we don't try to titrate the.
I mean, again 6.
Yeah. So what I feel in such scenario, no, it is the anti-inflammatory treatment which is playing the role. It's not the ATT. And you have to see that now evolving literatures are coming where we are treating the more hypersensitivity to tubercular protein. For example, one of our series is coming where we have predominantly used the methotrexate. Because even after completion of ATT also, you will see many of your patients in your clinic will come back with recurrence. So there was a time when we used to believe that if you give ATT, the chances of recurrence comes down. Maybe it is partially true. If you complete the ATT, I think the chances of recurrences reduces, but still the chances of recurrence is there. I think Dr. Neetu is here, who was a part of our the SANTU study. There we used a lot of immunosuppressive to control the immunosuppression. Sometimes it was used by our colleague as a first-line treatment also, and sometimes to prevent the recurrences also. So in cases of recurrences, I think it's better not to titrate the ATT. You have to think that how you can modify your anti-inflammatory doses. Like if it is oral steroid, if the patient is on oral steroid and in spite of 20 mg of oral steroid there is recurrences there or inflammatory activity is there, better not to blame the ATT. You have to think about adding an additional immunosuppressant.
And once ATT is stopped and then again coming with inflammation, so you are giving steroids or immunosuppressant.
Steroid and immunosuppressive, absolutely there is no role of ATT after that.
Okay, so the take-home message of first case is always suspect tuberculosis. History is again important. Like in this patient had a TB contact and all the tests positive. So do a thorough workup and monitor the ATT for liver side effects and modify the treatment accordingly and monitor the inflammation and treat the inflammation with steroids. Okay, thank you, Dr. Dalia.
Thank you, thank you.
Next, I invite Dr. Rajashree Nambiar, a case of with mysterious bulge.
I shall be presenting a case with a mysterious bulge. This is the story of a 28-year-old lady. She was 6 months postpartum, a lactating mother who presented with pain and redness in both eyes since 1 month. She had defective vision in both eyes since 2 weeks. She had consulted a local hospital and was started on topical and oral steroids, which was weaned off very early as the patient was lactating, and she had worsening of symptoms on tapering of steroids. Her visual acuity in the right eye was 618, left eye was 624. She had 1+ cells. This is the fundus picture of the right eye. There was presence of Uveitis with presence of disc edema, presence of submacular fluid, and also inferotemporally and temporally what you see are there was a slight elevation in the retina along with some choroiditis patches. Now if you see the left eye, there was also presence of vitritis with disc edema and submacular detachment, and there was a large choroidal mass which was seen inferotemporally, which was around 5 to 6 diameters in size. Now this is the OCT of the right eye, whereas you have this fluid at the macula, and this is the area where there is a choroidal elevation which is seen temporally. This is the OCT of the left eye, which is showing presence of submacular fluid with and in inferotemporally, if you see, there is a huge choroidal mass with presence of septae and intraretinal fluid. The B scan of the right eye showing a retinal detachment. Left eye we see a choroidal mass. Now this is the FFA, which shows in the early phase hyperfluorescence and hyperfluorescent disc, and similar picture in the late phases. The disc is leaking, and there is no pinpoint leak and pooling of the dye seen in the right eye. If you see the left eye, again you have a hot disc, and inferotemporally there is definitely pooling of the pinpoint leaks with pouring of the dye inferotemporally. So we decided to investigate the patient. Her basic VDRL etc. was negative, MAN2 was negative, IGRA was negative. These were done in view of the choroidal mass. ACE etc. was normal. ICG was not available at that moment, so it was not done. MRI brain and orbit showed a 7.2 into 2.5 millimeter thickening of the posterior wall, which was seen. But however, they advised a contrast and the patient wasn't willing for the same. With a diagnosis of bilateral VKH, we started the patient on a high dose of intravenous methylprednisolone 1 gram. This is a picture of the patient OCT after 3 days. We can see the submacular fluid, and also the choroidal elevation looks the same. Now this patient was discharged with oral steroids, and then she was started on Azoran after consulting a rheumatologist. Now this is the picture of the patient 1 month post-treatment. If you see, the disc edema has resolved, and also the fluid at the macula has resolved. The choroidal elevation is also resolved. There are pigmentary patches which are seen in the periphery. The left eye was, the disc edema again has resolved and no fluid again at the macula. Now the area where there was a choroidal elevation, we have an area of pigment deposit. A melanocytic proliferation is seen temporally, and also pigment patches are seen in the peripheral retina. If you see the OCT, if you see the macula is dry, and also in the left eye, if you see the submacular fluid has resolved, and the area of the choroidal mass has also flattened. So this is a picture of the patient 3 months on treatment. Again, this typical area, this pigmented patch at the area where there was a huge choroidal mass was stunning. So these are my questions to the panelists. in a case of VKH, where you get such a huge choroidal mass, should we look out for other etiologies like maybe a tuberculosis or a sarcoid or a secondary? And the second question is, in a postpartum lady or in pregnancy, does the management of VKH change?
I think very interesting case, Rajeshri. I must congratulate you managing it so well. My differential diagnosis in your case will be posterior scleritis.
Okay.
Because sometimes that kind of giant nodules kind of appearance can be seen there also. And it's a rare, I agree, that bilateral posterior scleritis is rare,
Very
but
rare.
it is not uncommon. Because we had a series with Woodfield Eye Hospital where we analyzed 18 cases of posterior scleritis. So it can happen also, and definitely it causes a lot of dilemma in differentiating between a VKH and all. One thing is that CNS signs are typically absent in posterior scleritis, and posterior scleritis patient typically gives history of pain. Now pain both VKH patient also can have, but VKH patient will have a little more vitritis, will have anterior segment granulomatous kind of inflammation like AC cells and all. How was this inflammation in that patient?
No, she was on topical steroids when she came to us. She had 1+ cells.
Okay. So sometimes it happens that the treatment, if the previous treatment will mask the
Yeah.
features, and pain also may be subsided because of that also. But I will try to take that history and ask typical few questions like whether the pain increases at night, anytime it happens, so that that because of the pain you got up from the sleep. So these are the very history. Sometimes patient actually can help you. And another history is that when you move your eyeball, is there any increase in your pain and all? So this kind of history can help. Ultrasound, yeah, it is there, but I think sometimes if you do the dynamic ultrasound, no, because it's a very difficult condition, bilateral posterior scleritis versus VKH to diagnosis. So only one possible way is if you go to that and increase the gain of the ultrasound, no? So sometimes you will see that the sclera is abnormally hyperreflective, which won't be seen in your VKH patient. But FFA is of no use because can give the same kind of photograph, same kind of clinical picture, pinhead early weak and the placoid pulling there. Is that the thing? And second question was on
In pregnancy and lactating mothers, does the
yeah,
management change anywhere?
Honestly speaking, I have treated only 3 patients only of VKH with pregnancy. So both the patients I have actually, they were 2 of them were already known case of VKH. So the moment they started up the inflammation, I just started the patient on administered Ozurdex.
Also,
But if you see the literature and talk to your rheumatology friends also, the azathioprine is considered as safe in pregnancy.
yes.
But I think only one not treated by me, one of the senior consultant in our Dr. SKJ, I think. So her patient actually, the patient was continued on azathioprine and she delivered. So there was no abnormality in the fetus. So azathioprine is considered by the rheumatologist as a safe in pregnancy. But because it is an anti-metabolite immunosuppressive, honestly, I am also very scared. So I'll be afraid to tell the patient that you take azathioprine and continue the pregnancy. I'll leave it to the obstetrician and rheumatologist.
We had a patient on Azoran, VKH patient on Azoran became pregnant, and rheumatologist told to continue Azoran, and she safely delivered. And in this patient, if it was posterior scleritis, that T sign might have gone because of the previous systemic treatment also. But honestly, in that fundus picture, post steroid fundus picture, some sort of depigmentation is there, like sunset, going for a sunset glow.
Even that
That
melanocytic
is also
proliferation
there.
which we see at the area where there was an elevation.
Very good observation, because if
Yeah.
you chronic, I forgot to mention that the only, whatever I have discussed, only point against was little bit, but the depigmentation was not that much you see in a convalescent case of
So,
VK.
but what about that localized pigmentation where there was a mass? Is it
I
because
think
of
it's just the RP hyperperturbation has occurred because of when it was resolving. That is my
it was a huge choroidal mass, so that's why we
mass,
thought
like,
whether it
yeah.
was a TB or a sarcoid, because I don't know whether
no,
BKH.
sometimes the giants they call giant posterior scleritis can
Okay.
have this kind of
It's a huge
proliferation also.
proliferation. Okay.
But yes, Risha is correct, but it can happen.
Anyway, we will keep the patient under close monitoring.
Thank you, sir.
Thank you, Dr. Rajeshri. Next, I invite.
I'll just make one point because Risa raised this issue. So I told no, the first year was we did 71 eyes of posterior scleritis with Moorfield Hospital and Shankarnathal. So two things I want to highlight which may help you. One thing was that we observed that T sign in ultrasound was not a pathognomic of diagnosis of posterior scleritis, and it was seen in only 63% of patients with posterior scleritis. And second thing, that pain, no, many a time I have seen people just ruling out the posterior scleritis. No, it can't be posterior scleritis, don't know pain. So in our series, 23% of the patient were absolutely asymptomatic, especially the children, the younger children. The posterior scleritis can occur without any pain, ocular pain, or any symptom also. So that it can be, we should remember that.
Yeah, thank you, sir. Next, case of relentless case of posterior uveitis by Dr. Neetu Latif from Giridhara Institute.
Good afternoon all. I'll be presenting a relentless tale of posterior uveitis. Case report: a 55-year-old lady presented to her OPD with complaints of blurred vision in the right eye since a week, similar to episodes of blurred vision in the right eye in the month of March and July 2023. Diagnosed and treated as toxoplasma retinochoroiditis elsewhere, improved with treatment. So in the month of March, she was treated with azithromycin and oral steroid. And in July, she was treated with a course of clindamycin and oral steroid. So when she presented to us, there was a anterior segment inflammation. There was fine KPs and AC cells of 1+. And as you can see in this fundus photo, there was vitritis with wit floaters. And these few yellow discrete lesions in the periphery was noted. And also RP scarring was noted in the periphery and the peripapillary area. OCT was suggestive of cystoid macular edema, and also you can see the stalagmite-like lesions in the vitreoretinal interfaces. FFA, the media was hazy, but we can appreciate the cystoid macular edema. So the pattern recognition here is multifocal peripheral retinitis with CME, query recurrent, differential diagnosis. Could it be a viral retinitis, toxoplasmosis, or masquerade? So we investigated, CMV titers were raised, the CD4 counts were normal, HIV negative. She was started on tablet valganciclovir 900 milligram BD. So after a week, she came to us with a worsening of the lesions, and the macular edema increased, and the stalagmite-like lesions also increased. So we thought, why not it be a acute retinal necrosis? So we changed to tab valsivir and started on a course of oral steroid. Followed up after 2 weeks, the lesions almost completely resolved. And even the macular edema subsided, and the stalagmite lesions also subsided. And she was doing well with this treatment, but her RNFL edema was persisting. So after a few months, she came with a recurrence. There was vitritis, new lesions noted in the infranasal quadrant with CME. So we increased the valsivir to 3 times, deflazacort 36 mg, and repeated the toxo titers, which was also positive for IgG, negative for IgM. There was also very suspicious activity in the peripapillary area. And then we noted that in the next visit, the lesion in the peripapillary area became much more prominent, and OCT through the lesion was suggestive of inner retinal and outer retinal changes. So we thought of revising the diagnosis, considered vitreous tap, stopped steroid, and then planned tap after 2 weeks. On stopping steroid, surprisingly, the peripapillary lesion resolved on its own. So we waited for another week, and then she came up with a flare-up. And at this point, when I see the lesions in the periphery, I felt like it was a peripheral serpiginous-like choroiditis appearance, not sure. So we did the PCR. PCR was positive for CMV, negative for HSV, VZV, and also the histopathology was negative. So oral steroid was started along with valganciclovir. We asked for a neurologist opinion. or MRI brain, patient not willing to do now. On restarting treatment, we reviewed her up after 2 weeks. Her BCVA is maintained to 624 and 36, and the final follow-up, the lesions were all, regressed. So what are we really dealing with? Is it an infection or a masquerade? Or is she really responding to the antiviral or oral steroids? And what if recurring again? To start antitoxo treatment or intravitreal antiviral or clindamycin, plan a AC tap for real-time PCR, or do we have to exclude TB in this case?
I think it's a very interesting case, Neetu. I feel it is a case of CMV retinitis, CMV retinitis, because nowadays the Sun classification says that ARN, the causes are only HSV, VZV. If it is a CMV, then we should not call it ARN, better to call it CMV. This is the latest guideline says. So let's call it CMV retinitis only. It was presented like a acute retinal necrosis. Only thing, it did not behave like normally we believe that acute retinal necrosis means immediately it will just spread circumferentially on. But CMV is an exception. If you see the replication type of CMV in contrast to HSV or VZV, CMV is extremely slowly replicating virus.
Okay.
So that's why I think the spread was just like a toxo. It was not like HSV, VZV. HS and VZV by this time I would have become PL negative with antitoxo treatment.
Yes, sir.
So that's one I feel. Second thing is that PCR already has shown that. So this is another pointer. Third pointer is I am little skeptical about that Uveitis article also. This is a very good article where they have showed that if you see the stalactite lesion then in OCT, then it is it is a indicator of a toxo. But
Yes,
we
sir.
have seen few cases of ocular TB where we have seen this kind of stalactite. I'm in contact with him only, so we are planning to write that up also. So I feel sometimes certain signs are described in literature. We have to keep in mind that these are not pathognomic of particular entity. These are just like laboratory investigations. Sometimes you have to decide on based on our clinical acumen rather than those signs that if we see that stalactite, whatever the picture is, it can be toxo. I think we should come out from that kind of mindset. Second thing is that another important point here is that CMV can occur in immunocompetent patient also. Your question was that whether it is infection and masquerade. Yes, CNV, there are a lot of reports you have also showed, I think, that CNV can be seen in immune-competent patient. So same thing happened with us. This report just got published in IGO now. So the young lady came to me and it looked like a typical CMV retinitis. We have treated with ganciclovir injection and patient responded. Only thing which bothered us was 23-year-old lady, why she got that CMV retinitis. So I just gave her patient was from Gujarat. So I just gave her an idea that you better do a PET scan. You can go back and do the PET scan and come back for that. And patient did not come back for follow-up. After I think 3 months, I got a call from Mumbai. They told that, so what happened? The patient went there, did a PET scan, and it showed that there was a Hodgkin's lymphoma. So sometimes if there is some underlying malignancy, that can lead to immune suppressions, which may not reveal in your CD4 count and all. So these are the patients where there is a CMV retinitis and you can't explain that there is no immunosuppression. I think it's a good idea to do a PET scan or at least send to an oncologist for overall actually evaluation of the patient that whether there is any underlying malignancy is there or not.
Neetu, in this patient, CD4 count was normal and even PCR was also negative for CMV, you know. And
PCR was positive for CMV.
okay. Vitreous PCR was positive.
Yeah, positive for CMV.
And how often you do serum IgG for viral?
No, herpes virus is no point of doing serum evaluation because these are the ubiquitous organism. Even if you do my CMV or HSV may be elevated because it is there. 95% of us are having the viruses inside us. There's no point doing that and treating them based on that serology.
So, do you think it could be a TB? Like
TB will be in my last.
last. Okay. Thank you, sir.
We move on to the next case, I invite Dr. Anju Kuriakos, who is a medical retina and uvea specialist at Chaitanya Eye Hospital and Western Eye Hospital, for her presentation, Beyond the Eye, Vision Blight and Mother's Plight.
Good afternoon, everyone. I am going to present a case of a 38-year-old female came with complaints of blurring of vision in her left eye for the past 2 weeks. She has no history of pain, redness, or photophobia, no history of trauma. She has a significant past history of similar episodes in the past 6 months. She was treated with topical and systemic steroids elsewhere, and she was treated in Ayurveda hospital for 1 episode in that. On further examination, she gives her history of 2 pregnancy losses prior to the development of this ocular symptom. One was first trimester and next was mid-trimester loss, for which she was evaluated from the obstetrician, for which APLA was negative. On examination, in her right eye it was 6.6, vision was 6.6, and left eye it was 6.60. Lids and adnexa was normal. Cornea shows diffuse KPs in the left eye. Anterior segment showed 2+ cells. And iris and lens pigments were noted in the anterior lens capsule. Right eye fundus was normal. Left eye fundus shows severe vitreous haze with yellowish white fluffy retinal lesion seen in the posterior pole along the inferior arcade. We started on topical steroids and topical antibiotics, and basic uveitic workup and torch panel was sent, in which basic uveitic workup was normal, and in torch panel toxo was positive. So she was started on triple therapy, but we lost follow-up of that patient. So my questions will be, because she was started on how will the oral steroids alter the clinical picture without systemic treatment? Because she was started previously on systemic steroids before coming to us.
Yes, steroid can alter clinical picture, but lucky that there was no actually flare up of inflammation in such cases. Like toxo and ARN, these are the cases like sometimes if you, without any antimicrobial treatment, if you start oral steroid, then it can flare up the inflammation. But toxo, sometimes I have seen that there can be reduction in the vitreous haze also, and the lesion may remain same.
But then she was inconsistent with her treatment, I think. Even with the after second visit, she lost follow-up with me also.
Yeah, correct.
So next question will be, given the patient's history of multiple miscarriages, should further vasculitic workup be considered, because only APLA was done from the obstetric side?
So this patient required detailed workup for the toxo, because toxo also known to cause abortion and miscarriages. So I think you are on the right track. Autoimmune disease like SLEN will be this rarely can present like this. Yeah, you can do one ANA or specific panel.
Was the torch panel necessary in this case, or would toxoserology alone has been enough?
I think toxoserology will.
Yeah, one doubt to Dr. Partho. What is your drug of choice, sir, in a patient with no sulfa allergy and toxo diagnosed? Drug of choice.
Bactrim DS I prefer, and I prefer clindamycin also. But while giving clindamycin, I always tell the patient about the side effects of the clindamycin. But I feel that. And second thing is that intravitreal clindamycin is very good choice for these patients where there is a macula encroaching or macular lesions of toxo. Only thing is that we have to remember that the half-life of the clindamycin is 5 to 6 days only. So if you are giving clindamycin, you have to give it every weekly. And before starting the treatment, you should tell the patient that I will give injection and every week you need 1 injection. There is no point giving 1 injection and waiting to see the response for 2 weeks or 3 weeks. That's not going to work.
And you add azithromycin along with, or?
Azithromycin I don't give.
Okay, thank you, Anju. Next I invite Dr.
If I give intravitreal, then I give Bactrim DS and intravitreal. Yeah. Bactrim DS I think we should always give. to 8 weeks.
Now I welcome our chairperson, Dr. Partho Pratim Datta Muzumdar, for his keynote address, Updates in the Management of Uveitis.
Good afternoon. Thank you, Dr. Rajashree and Risha, for giving me this opportunity. So the topic, as you can see, the update in the management of uveitis. So I'll just divide my talk into first part. I'll talk about the update, what is the recent management in the uveitis, and second, I'll just conclude with 7 take-home points for not missing out or not committing any mistakes in the management of uveitis. So I don't have any financial interest in any of these drugs. So if you see the evolution of the drugs in uveitis, you will see that we are following the rheumatologist or the transfusion medicine specialist. What all they are using, we have started incorporating in our practice. So it started with corticosteroid, then we moved to immunosuppressive and biological. So the basic idea is to immune suppress the entire the body cells. So if you see the corticosteroid, what we do, we try to take the lymphocyte from intravascular space to the extravascular space, that such as bone marrow, spleen. So we just shift the lymphocyte from intravascular space to the extravascular space. Whereas in immunosuppressives, what we do, we try to kill the rapidly replicating cells. Whenever there is an inflammatory stimulus, so the lymphocytes, macrophages, they will come and start replicating at the site of inflammation. So immunosuppressives like anti-metabolite, they will just deplete these cells of metabolism, and sometimes the cytotoxic, they will just cause the lysis of the cell, and they will basically cause the immunosuppression by killing those cells. So that's why immunosuppressives are sometimes considered as a very prone to have much more side effects. So that's why there was a continuous effort to identify some agents which will cause theoretically at least minimum side effects. So that's how the biological came. The biologicals are basically the substances. These are biologically active substance, and why they call biologic, because they are made with the help of biological technique, like we have the monoclonal antibodies and all. So they are basically, they just interfere with the transmission of the inflammatory cascade. Like if you see if there is a cytokine producing cell, so there will be cytokine production. So biological will go and just block the cytokine production rather than causing damage to the inflammatory cells. So the pathway will be disturbed, but the cells will remain intact. So that's how we have so many biologicals. I'm not going to discuss into that. One thing we have to remember, that we have so many varieties, and now we have fully human antibody. So we believe that fully human antibody like adalimumab and all these are, they won't cause any reaction. But you have to understand, anything foreign to our body will cause some kind of reaction. So even the fully human antibody, monoclonal antibody also can cause some inflammation. So that's why these drugs are often prescribed with oral methotrexate or oral steroid. Now, tips for biological uveitis, if you want to decide, first of all, you have to rule out the infection, discuss your treatment plan with patient and rheumatologist. Combination of the methotrexate, as I said, it is very important, because you can maintain the long-term immunosuppression. When a period of inactivity, when the disease is inactive, then you can stop the biologic and continue the patient on methotrexate. And monitor your patient regularly, keep a watch on recurrence of inflammation. Now let's come to the good, bad and ugly of a biologic. So the good part is, it is very useful treatment option in the treatment resistant cases. It is available as a injectable formulation, compliance is high, and relatively faster onset of action. If you see the commonly available adalimumab, it's actually T max is after a single dose is almost 5.5 days. So it's a relatively rapidly acting drug which can be used in your clinical practice. I'll give you an example. A 52-year-old lady with known case of necrotizing scleritis for last 6 years, and you can see the patient was treated with on corticosteroid, cyclophosphamide, azathioprine, and resistant to all drug. IUP was significantly high. I'll just cut short the discussion so that I can finish all the slides. So the IOP was so high, the patient was in need of a Ahmed glaucoma valve. But because of active scleritis, it was very difficult to start the patient on, allow the patient to go for surgery. So here we have decided to inject the patients with one TNF alpha blocker, which is called golimumab. It's just like adalimumab only. So and methotrexate, we treated the patient. There was prompt resolution of that, and finally the patient underwent Ahmed valve implantation. So sometimes in conditions, for example, a patient with scleritis has developed a rhegmatogenous RD, and your vitreoretinal surgeon want to treat the patient. So you need a prompt control of the treatment. So in such scenario, where the treatment is not responding to any other modalities of treatment, these agents can be helpful. Now another scenario you see here, the oral steroid was used and oral methotrexate was used, and this scleritis patient kept on getting the recurrence, and there was almost perforation. So now in this perforation with active scleritis, you need to control the uveitis, and you have to scleritis, and then only you have to go for patch graft. So biological can be a very useful alternative in this scenario. So it decreases the recurrence rate of inflammation. So you have to little act early and taking a decision on biologic. So sometimes what happen, you will attend various webinar or lectures where people will tell you that the biological should be used at last. First you treat the immunosuppressive. Sometimes like where the scleral integrity or the patient's visual potential in danger, for example, a patient of Behçet disease, no point of treating the patient with 2-3 immunosuppressive, spending time when there is already damage has occurred, then to shift to biologic. So in these patients, you have to shift this patient to biological little early compared to the other patients. The bad for us is in a country like India, you can see it is very expensive. The cost per dose of adalimumab, yes, the biosimilar of adalimumab, which is administered every 15 days, is 6,000. And this is the cost if the patient is, if you are telling the pharmaceutical company to give it to the patient without going to pharmacy, then this is the cost. In pharmacy, the cost is much more higher. So cost is a very big factor, like rituximab, which is often considered as a gold line treatment for scleritis also. So that is also become very expensive. So cost is the bad thing about the biologic. The ugly part is of the biologic is that the increased risk of infection. The TNF alpha blocker, when we talk about, so TNF alpha is a cytokine molecule. Now what is the function of cytokine molecule, we are not going to discuss, but one important thing we should remember is TNF alpha is responsible for safeguarding us against Mycobacterium tuberculosis. So in a country like tuberculosis, if you are giving anti-TNF blocker for a long time, patient is susceptible to develop or contract TB much more commonly than the other patients. So that thing you have to keep in mind, and you have to tell the patients also that you may be prone to infections. So this is a patient of JIA treated for at 4-year age. It was diagnosed, and the patient was treated with oral methotrexate and adalimumab for a long time, and developed pulmonary TB after 9 years of treatment of adalimumab. So sometimes it can happen, but it is treatable. The child was successfully treated with ATT, but patient also developed some choroidal nodule, which was due to the tuberculosis only, and this was also treated. This is another patient on long-term immunosuppression for 8 years and developed a toxoplasma lesion, but it was managed with intravitreal and systemic medication. So it is all about balancing when to use the drug. You have to understand that it's all about balancing the risk and reward. So you have to take the call judiciously. Now there is another molecule which has emerged out as a poor man's biological, you can call the JAK inhibitor. So JAK signaling, again I am not going into that, it is another pathway which prevents, which is used in the inflammation. So this drug actually prevents that pathway. It is FDA approved for rheumatoid arthritis, psoriatic arthritis and ulcerative colitis. So the tofacitinib is the very useful molecule. It is very useful in exudative RD and various other conditions. Why? It is basically small molecule, so theoretically it is more common to more easily it can penetrate the blood-retinal barrier and can reach the eye easily. So that's why tofacitinib is becoming very popular. So we have the largest series from this scleritis. It was our first case report from India, and then we with Professor Ramanan of Bristol, we use it first in the children in uveitis and scleritis, and the responses is really good. The tofacitinib scleritis also we have published a large series on adult patient also. So responses are good. And who are the ideal candidate? The patient who cannot afford the biological treatment, the needy people for whom the biological cost is too high. It can be done because each tablet is 20 rupees only. So per day cost is only 40 rupees. Now, these are some examples. I'm not going into that. These are all treatment resistance cases of scleritis which ultimately responded to tofacitinib. This is another important to highlight that tofacitinib sometimes can cause viral reactivation. These patients of scleritis responded but developed some viral stromal keratitis which was treated with antiviral, and there was no need to stop the tofacitinib treatment. Also, some patients we have encountered that herpes labialis is developed after 1 month of use of tofacitinib. So it's not that we are only promoting the tofacitinib for all cases. You have to remember that the herpes infection can be there. So you have to tell the patients about that. And another side of that, there is a history of tuberculosis related cervical lymphadenopathy, and we could treat them without there was any reactivation of the TB. So this is another children who was not responding to methotrexate and mycophenolate, but finally responded to tofacitinib. So just I'll conclude with 7 signs to avoid in uveitis management, which will be helpful for all, but it is a common all only. First is that avoid the incorrect use of eye drop. You have to understand that many a time we treat the posterior segment lesions with eye drop. So posterior uveitis, panuveitis and intermediate uveitis, you have to understand that eye drop cannot treat the drop in vision. So you have to always use the systemic medication. Second, incorrect use of using topical drop is don't use the cyclopentolate. Cyclopentolate is a medicine which is chemoattractant. That means it will attract the inflammatory cells to the site of inflammation. So treating the inflammation with cyclopentolate is just like calling a bull to come and hit you. Now, sometimes what happens, you start the medicine atropine long-standing, which has a long-standing effect, and the topical steroid you gradually taper down. So if your tapering of the topical steroid is too high, quickly you are just tapering the topical steroid, but patient is on atropine, there are chances that patient can develop synechia in dilated pupil, and that patient will cause a lot of trouble because you will have a lot of photophobia and all. So beware of that. Any patient, for example, this is a patient of anterior uveitis treated with iridocyclitis. A lot of investigation was done and started on topical steroid and cycloplegic. But this is the patient, you can see the view. If you are doing a 90D examination, it will look like this. But if you just do the peripheral examination, you can see that this was a case of acute retinal necrosis. So dilated fundus examination is must. Second important thing is that always look beyond the eye. Sometimes what happens, we don't look beyond the eye and only treat that eye. For example, a patient of anterior uveitis, if you don't try to delineate it that how far the spectrum is, you will miss the other ocular manifestation. And if you don't take care of all these things, then you will miss the systemic manifestation also. That's why the Chinese saying is there that the unlucky doctor treats the head of the disease and the lucky doctor its tail. So you have to treat from head to tail of the disease. Now, I'll give you an example. If you just treat a case of bilateral granulomatous uveitis only with topical steroid and cycloplegic, you will miss seeing that the patient may have vitritis or exudative retachment. So this patient, ultimately the extended spectrum says the patient may have alopecia, vitiligo and tinnitus. So you have to overall give the immunosuppression to control the overall disease, not only the systemic medications. So this is again another patients was treated with HLA as a fibrinous reaction, so was considered as a HLA-B27, but HLA-B27 was negative. Patient lost to follow-up. The patient went to another hospital, tertiary center, and there it was diagnosed, treated as a TB because Montu test was 20 millimeter. So, and HLA-B27 was negative, so they thought that it is TB only. So treated with TB, patient developed deranged LFT, recurrence not stopped, kept on getting recurrences. Patient also developed backache by that time, and again when he came back, we again repeated the HLA-B27. This time it was positive. So rheumatologist diagnosed it as a ankylosing spondylitis. So sometimes you have to understand that we cannot treat the laboratory investigation, and sometimes HLA-B27 can become positive at later part of the disease also. Next, few drugs, these are notorious to cause inflammation, so always take the history. If you don't know the name, the commercial name, just Google search, you'll get the name and check that whether the uveitis is because of any of this drug which are the culprit. And don't use the suboptimal use of drug, like this kind of the site-threatening condition. No point of treating these patients with only immunosuppressive, biologic, or a low dose of steroid. What you have to do, you have to understand that all this immunosuppressive we are discussing, they have a long actually onset of action. You see here, mycophenolate, it takes month to act. Methotrexate takes at least 3 months to start acting. So these are the drugs which cannot help them. Only drug which can help is that the methylprednisolone or the IVMP, pulse steroid. So it has been seen that it takes almost, in an inflamed eye, it takes only 2 hours to reach the eye. So the pulse corticosteroid is a valuable option here. My last slide, this is about the children. That mistake in treating the uveitis we do in children is that you have to remember that JI is a notorious cause. Most of the childs are blind in pediatric uveitis because of this condition. So you have to always remember how to identify that. So complications are very high. You have to see any child presenting with BSK, tilting of head, squinting. You have to make sure there is something gross abnormal. Hunt for the inflammation. Always treated as a because JIA are white eye uveitis, so often treated as a allergic disease. So you have to sometimes take them for examination under general anesthesia. Immunosuppressive remain the mainstay. Don't treat a children with uveitis with topical steroid. Steroid drops are not for the children. Always you have to rely on the immunosuppressive, and you have to understand that lens, intraocular lens, there is no fixed rule. You have to carefully see that whether the child is inflammation is controlled or not. Otherwise, just leave the child aphakic. Sometimes it's just our ego. For that we put the lens, and finally the child will develop lot of other problem, and finally that require IOL explantation. So remember that IOL is very there no fixed rule. You have to decide very carefully, and the drops should not be used. Very minimally you should use in treating the pediatric children. Thank you.
Thank you, Partho sir. That was an excellent talk, and especially the pearls and management was very useful. We are on time, and any questions, maybe you can have it on, during the tea, you can share it with sir. Thank you to all the speakers and the delegates for attending the session.